Good morning, all of you. Today's topic is surgical management of locally advanced differentiated thyroid cancer. As we all know, differentiated thyroid cancers comprise 90 to 95% of overall thyroid cancers. They are associated with very good prognosis among all the thyroid cancers. Before proceeding with the surgical management of locally advanced cancer, let me first go back and talk something about the T staging and the prognostic factors, ATA prognostic factors for recurrence. So the T staging as per the AJCC 8, T1 is any tumor less than 2 centimeter in greatest diameter limited to thyroid. T2 is the one which is greater than 2 but less than 4 centimeter limited to thyroid. T3 is sub-classified into T3A and T3B. T3A is greater than 4 centimeter limited to thyroid. T3B is the tumor with gross extrathyroidal extension invading only the strap muscles. Strap muscles means sternohyoid, sternothyroid, thyroid, and the omohyoid muscles. T4 with gross extrathyroidal extension beyond the strap muscles. Tumor invading subcutaneous soft tissues, the larynx, the trachea, the esophagus, and or the recurrent laryngeal nerve, classified into group 4A. And T4B is tumor invading the prevertebral fascia or encasing carotid artery or the mediastinal vessels. So when we talk about locally advanced thyroid cancers, we mainly mean with the extrathyroidal extension from T3B onwards. Now, the risk of recurrence according to ATA guidelines, low risk, intermediate risk, and high risk. Which are the low risk group? The one with papillary carcinoma of the thyroid with no local or distant mets, no remaining macroscopic tumor tissue, no invasion into surrounding structures, no aggressive histology. And if iodine 131 is given, no radioactive iodine with metastatic foci outside the thyroid bed. The PAPCA with no vascular invasion, and those which are clinically N0 or less than 5 micrometastasis. The one which is intrathyroidal encapsulated follicular variant of papillary thyroid cancer, interthyroidal well differentiated follicular thyroid cancer with capsular invasion and no or minimal less than 4 foci vascular invasion. Intrathyroidal papillary microcarcinoma including BRAF V600E mutated. So this group comprises the low risk group. Why the classification is important? Because the low risk group is less likely to recur as compared to the intermediate and high risk group, which we will study some time later in the discussion. The intermediate risk group, PAPCA with microvascular invasion of the tumor to perithyroid soft tissues, radioactive iodine amid metastatic foci in the neck, the one with aggressive histology, the tall cell, the hobnail variant, and the columnar cell carcinoma. Papillary thyroid cancer with vascular invasion, clinically N1 or greater than 5 pathological N1 neck. Multifocal PAP microcarcinoma with extrathyroidal extension. And the high risk group with macroscopic invasion into the perithyroid soft tissue, the one which are incompletely resected onto table, the one with distant mets, the pathological N1 with metastatic lymph node being greater than 3 centimeter, and follicular thyroid cancer with extensive vascular invasion. So the intermediate and the high risk group are more in favor of recurrence, and they may require post-operative radioactive iodine later. So as we all know, the thyroid is in close proximity to the critical anatomical structures like the recurrent laryngeal nerve, the trachea, the esophagus, and the larynx. So whenever there is some extrathyroidal spread of tumor, it is more likely to involve these structures: the recurrent laryngeal nerve, the trachea, the esophagus, the larynx. So, which are the structures most commonly involved by the locally advanced thyroid cancers? The most commonly involved is the strap muscles. Strap muscles is involved in 52 to 66% of the cases, followed by the recurrent laryngeal nerve, the trachea, the larynx, the hypopharynx or esophagus, and followed by other nerves and vessels of the neck. Introduction. What is locally advanced thyroid cancer? They comprise, they comprise a small subset of differentiated thyroid cancers in which there is gross tumor spread beyond the thyroid into the nearby structures such as the larynx, trachea, esophagus, recurrent laryngeal nerve, or the major vessels of the neck. Though differentiated thyroid cancers are associated with good prognosis, these locally advanced tumors are associated with worse prognosis, higher local recurrence, and lower disease-free survival. Surgical management is challenging due to involvement of nearby structures and their complex anatomy. There has been a lack of uniform guidelines for the management of locally advanced thyroid cancer. What is the definition of locally advanced thyroid cancer? Locally advanced thyroid cancer is defined as gross tumor extension beyond the thyroid capsule involving vital neck structures such as the recurrent laryngeal nerve, the trachea, the larynx, the esophagus, and the major vessels of the neck, the internal jugular vein, the carotid artery. They comprise about 13 to 15% of the differentiated thyroid cancers. As such, microscopic extrathyroidal extension does not upstage the tumor or there is no impact on the prognosis. The prognosis of DTC is generally very good. However, locally invasive differentiated thyroid cancers have poor oncological outcomes and higher rates of recurrence and distant mets. The primary goal of surgery in differentiated thyroid cancer is complete eradication of all cancer tissue, total thyroidectomy. However, in case of locally advanced cancer, it is complete eradication of cancer tissue with safe margins. This is not achievable in all advanced cases because radical resection is challenging and critical anatomical structures may be damaged. So, what is the acceptable margin? Options for achieving acceptable disease-specific survival include incomplete removal of the primary tumor in cases of microscopic or macroscopic residual disease and post-operative radioactive ablation with thyrotropin suppression. At present, the extent of surgery in patients with locally invasive differentiated thyroid cancer remains a matter of debate. So, how do we evaluate a case of locally advanced thyroid cancer? How do they present in the OPD? They present most commonly as a palpable neck mass in more than 90% of the cases. These are the most to the least symptoms. The most common symptom is hoarseness or voice change due to recurrent laryngeal nerve involvement, dyspnea, stridor, or hemoptysis due to laryngotracheal invasion, dysphagia due to esophageal invasion, and sometimes there may be symptoms of superior vena cava syndrome. Detailed preoperative staging of the primary lesion is essential. It helps in proper counseling to the patient regarding the surgical plan, the expected complications, and the post-operative treatment. Preoperative laryngoscopy should be done in all patients with thyroid nodular disease, even those without symptoms. Why is it important? Because hoarseness is an unreliable sign of recurrent laryngeal nerve involvement. It is present in only 1/3 of patients of vocal cord palsy. That means even though the voice may be normal, there are chances that he may be having recurrent laryngeal nerve palsy. So laryngoscopic evaluation is very important. The important investigations after laryngoscopy is ultrasonography. Ultrasonography, it helps in identifying both the primary tumor invasion into the surrounding tissue as well as it helps in identifying the nodal mets in the central and the lateral compartment. For the thyroid, it shows suspicious features of extrathyroidal extension such as increased degree of capsular abutment, capsule disruption, irregular bulge on the thyroid contour, and infiltration of strap muscles. It is the method of choice for detection and diagnosis of cervical lymph node mets. It is more sensitive for lateral than for central lymph node metastasis. Ultrasonography. The ultrasonography features which suggest lymph node mets are focal or diffuse hyperechogenicity, microcalcification, cystic change. The ovoid change is shape of the lymph node is changed to round shape, and there is loss of hilar echogenicity with abnormal vascular patterns. Apart from ultrasonography fine needle aspiration of suspicious lymph nodes should be considered to confirm the presence of lymph node mets. So here we have seen both ultrasonography helping us in determine extrathyroidal extension and the ultrasonographic features of the lymphatic metastatic lymph nodes. CT and MRI have a role to play in locally advanced thyroid cancer. The CT and MRI is helpful in evaluating anatomical relations between the tumor and surrounding visceral structures in locally advanced differentiated thyroid cancer. Because however sensitive and the ultrasound may be, it is always user dependent. CT and MRI have advantages in evaluating substernal extension of the thyroid tumors, cervical and mediastinal lymph nodes, and tracheal involvement. CT with contrast enhancement is recommended to evaluate central and lateral metastatic lymph nodes with locally invasive thyroid cancer. Lee reported that combination of CT scan and ultrasonography is more sensitive than ultrasonography alone in cases of metastasis to retropharyngeal and superior mediastinal lymph nodes. If there are symptoms suggesting laryngotracheal invasion, a flexible endoscopic evaluation of the larynx and trachea may be done preoperatively. If preoperative symptoms of pharyngeal or esophageal dysphagia is there, a flexible esophagoscopy or endoscopic ultrasonography may be considered. In cases with suspected invasion of the surrounding structures where it is difficult to evaluate the length and depth of invasion by CT or MRI, bronchoscopy and esophagoscopy is used to evaluate the extent of invasion for surgical planning. What is the principle of surgery in locally advanced thyroid cancer? The principle is total thyroidectomy with removal of all gross tumor with the aim for R0 resection. However, with preservation of vital and functioning nearby structures. It is a balance between complete tumor removal and preservation of functions of the adjacent structures. Adjuvant therapies augment surgery but do not replace the resection. Now, starting with strap muscle invasion. It is the most frequent extrathyroidal involved structure. It has not been found to correlate with decreased survival. The management of strap muscle is relatively straightforward, which requires only wide local excision with negative margins. However, too radical excision of the strap muscles should not be done because they may be required in reconstructing the pharyngeal or the laryngeal defects when there is small full thickness defects. Song et al. Reported that disease-specific survival rate of patients with small tumors with gross extrathyroidal extension into strap muscles was not different from that of T2 disease. It was better than that of T3A disease. In an analysis of 3,000 patients, Park et al. Reported no difference in 10-year cancer-specific survival among patients with gross extrathyroidal extension into strap muscles, those without extension, and those with microscopic extrathyroidal extension into the strap muscles. So strap muscles carry invasion carry no overall worse prognosis for the patient, even though it may be gross invasion. Management of the involved recurrent laryngeal nerve. After strap muscles, recurrent laryngeal nerve is the most commonly involved structure, and it is the most common form of major extrathyroidal extension in locally advanced thyroid cancer. The invasion is seen in 30 to 60% of locally advanced thyroid cancer. The recurrent laryngeal nerve may either be involved by direct extension of the tumor or by extranodal extension of the central compartment lymph nodes. The underlying principle of managing involved recurrent laryngeal nerve is to resect all gross tumor with every attempt to preserve the functioning nerve. Means if the nerve is functioning, it has to be preserved. However, not always. So, if a recurrent laryngeal nerve is encased or invaded by tumor and there is a pre-op ipsilateral vocal cord palsy, it is the recurrent laryngeal nerve is always resected and reconstructed. However, when there is a pre-op, there is contralateral vocal cord palsy or intraoperative, there is damage to the opposite recurrent laryngeal nerve, then the ipsilateral recurrent laryngeal nerve should be saved and preserved. When bilateral cords are mobile and shaving off is possible with no gross residual disease, the recurrent laryngeal nerve should be preserved. When shaving not possible because of the gross residual disease and the encased recurrent laryngeal nerve is the only site for R plus resection, then the recurrent laryngeal nerve should be resected and reconstructed. If it is one of the sites for R plus resection, consider shaving as much as possible and preserving the recurrent laryngeal nerve. That means only in ipsilateral vocal cord palsy the nerve is directly resected and reconstructed. Otherwise, it is always tried to save and prepared, except in case where it is the only site for R plus resection. So, in summary, preservation preferred if nerve function is intact, even if microscopic disease remains R1 resection, as it doesn't worsen survival if it is followed by radioactive iodine. Sacrifice considered only if preoperative vocal fold palsy is there and nerve is encased by tumor, or only gross residual disease on the functioning encased nerve and tumor cannot be shaved off. If a nerve is resected at surgery, an attempt must be made to immediate repair. Options are end-to-end anastomosis, cable grafting with the greater auricular nerve, or answer to recurrent laryngeal nerve anastomosis, or vagus to recurrent laryngeal anastomosis. These are done immediately to minimize misdirected regeneration of adductor and abductor and adductor fibers. In a retrospective review by Nishida et al., in patients with preoperative functioning vocal cords, despite nerve invasion, the nerve preserved group did not show local or regional recurrent or distant metastasis when compared with the nerve resected group. Intraoperative nerve monitoring. So, in case of locally advanced thyroid cancer, there is the anatomy is distorted, and intraoperative nerve monitoring, it helps in identifying the nerve. It helps in prognostic information about functional status of the nerve during and after removal of the tumor. Intraoperative nerve monitoring helps guide when not to resect recurrent laryngeal nerve, even when it is invaded and there is preoperative palsy. Since of about 33% of recurrent laryngeal nerve with preoperative palsy, which can be stimulated by intraoperative nerve monitoring, and attempt at preservation of such nerve should be made. So even if there is vocal cord palsy, or the recurrent laryngeal nerve is palsy and it can be stimulated during the surgery, and attempted preservation should be made. Despite this advantage, the utility of intraoperative nerve monitoring in Indian scenario is restricted, and it cannot replace the anatomical identification of the nerve and careful surgical techniques. Now coming to tracheal invasion. Tracheal invasion accounts for one-third cases of locally invasive thyroid cancer, but frank intraluminal extension into trachea is less common. Airway invasion can be suspected on symptoms and confirmed and mapped on imaging and flexible scoping. Now, since classification of tracheal invasion is divided into 4 stages. Stage 1, when the tumor abuts the external perichondrium of the trachea but does not invade it. Stage 2, when tumor invades between the rings of the trachea or invades the tracheal cartilage. Stage 3, when it extends through the cartilage into the lamina propria of the tracheal mucosa with or without mucosal elevation. And 4, when it extends through the entire thickness of the mucosa, expands the tracheal mucosa extending into the lumen. So here there is abutment, here there is infiltration. Stage 2, stage 3, it extends up to the lamina propria, the mucosa is normal, and stage 4 is there is submucosal, which is extends beyond the mucosa into the lumen. Now, McCaffrey divided involvement of the aerodigestive tract into 5 stages. The tumor is located within the thyroid capsule. There is no invasion of the airway or of the muscle. In stage 2, the tumor invades the perichondrium or firmly abuts the muscle, but does not invade the cartilage. In stage 3, there is invasion through the airway perichondrium into the cartilage or deeply into the muscle. And stage 4, when it invades through the perichondrium and cartilage and it deforms the submucosa. And stage 5, when there is gross transmucosal involvement by the carcinoma. Now, why this classification is important? The classification is important because it helps in determining the procedure to be done. For superficial tracheal invasion, a safe resection can be done. For deep and intraluminal extension, such as SIN classification 2 and above, a full thickness resection needs to be done to ensure safe margins. A wedge or a window resection can be done only for a small length of tracheal invasion. Circumferential resection with end-to-end airway anastomosis gives adequate margins for intraluminal tracheal disease and facilitates repair. Moritani et al. Recommend performing window resection for tumors that have invaded up to half circumference of the tracheal wall, while others recommend sleeve resection when tumor has invaded the tracheal mucosa, because when there is tracheal mucosal involvement, there is a possibility of spread to the opposite side as well. McCaffrey also recommend treatment options according to the various stages. When it is limited to the thyroid, total thyroidectomy is done. When it abuts the perichondrium or there is involvement of the cartilage, he says there is total thyroidectomy and shallow partial thickness excision should be done. When there is submucosal or there is involvement of the mucosa, there is complete aerodigestive tract resection should be done. Siegel et al. Reported that 5-year survival rate was equivalent between the patients with radical surgery to excise all microscopic disease and with surgery with macroscopic disease followed by radioactive iodine for microscopic residual disease. That is shaving procedure. Nishida et al. Also concluded that differentiated thyroid carcinomas with superficially limited invasion can be treated successfully by safe excision, and those with deep invasion should be treated by resection of the invaded trachea. When performing tracheal resection, critical considerations include the tracheal blood supply, which is by the inferior thyroid artery, which runs in the lateral groove, the length of the involved segment, and preservation of the recurrent laryngeal nerve. Now, resection of 5 to 6 centimeter of the trachea can be performed with primary anastomosis without tracheal or laryngeal mobilization. If mobilization needs to be done superiorly, it can be done by division of the thyroid musculature, the thyroid membrane, and the suprahyoid musculature. Division also yields an additional length to ensure a tension-free anastomosis. Inferiorly in the chest, several centimeters can be gained by sternotomy and hilar mobilization. Now we come to the laryngeal involvement. Larynx may be involved via the paraglottic involvement, or there may be direct involvement of the tracheal cartilage, thyroid cartilage at the upper pole of the thyroid. The main options for surgical treatment of laryngeal invasion are Shaikh procedures, excision of the framework, partial laryngectomy, and total laryngectomy. Shaikh procedures should be done only in lesions abutting the laryngeal cartilage. Partial laryngectomy is done when the lesion is lateralized and it has not invaded the mucosa. For patients with intralaryngeal involvement across the midline, when there is involvement of cricoid cartilage or intraluminal hemorrhage, total laryngectomy is the appropriate surgery. Esophageal involvement. Whereas the mucosa of the esophagus and pharynx is relatively resistant to direct invasion, the muscle layer may be readily invaded, leading to significant compressive dysphagia. The most commonly associated esophageal involvement is restricted to the muscularis, and the tumor can be dissected of the underlying mucosa by developing a submucosal plane without difficulty. Esophageal luminal mucosal involvement is rare, but it must be treated with partial esophagectomy and reconstruction. Vascular involvement. The most commonly involved major vessel in thyroid cancer is the internal jugular vein. It is usually involved by the bulky nodal disease with extranodal extension. Occasionally, there may be tumor thrombus extending into the internal jugular vein and into the mediastinal major veins. The carotid is much less commonly involved in differentiated thyroid cancer. Single internal jugular vein involvement can be resected without any major issues. For bilateral major vein resection or tumor thrombus into major veins, or in the when there is carotid involvement, resection has to be planned with simultaneous reconstruction, and so a vascular surgeon should be nearby. Now coming to neck dissection. So in locally advanced thyroid cancers, along with thyroid, what is to be done for the neck? Prophylactic central compartment neck dissection should be considered in patients with clinically node negative locally advanced differentiated thyroid cancer. In a large-scale retrospective study of 4,300 patients, Ito et al. Found excellent 10 to 20-year recurrence-free survival rates after prophylactic central compartment neck dissection. The recent guidelines of European Society for Medical Oncology suggested that prophylactic central neck dissection to improve renal control in invasive papillary thyroid carcinoma. So in N0 neck, in locally invasive thyroid cancer, at least a ipsilateral central compartment neck dissection has to be done. The panel cannot recommend for or against prophylactic lateral neck dissection for clinically N0 locally advanced papillary thyroid carcinoma T3 or T4, and there is no evidence that procedure leads to reduced recurrence or improved survival. So in N0 neck, at least an ipsilateral central compartment neck dissection is being encouraged. A subgroup analysis is based on ATA risk stratification showed significantly lower recurrence rate after prophylactic central compartment neck dissection in intermediate and high risk group, whereas there was no significant difference in the low risk group. Now, what happens in the N plus neck? Almost half of the metastatic lymph nodes in the lateral compartment are in level 3 and in level 4, while other half are in the level 6, which is in the central compartment. If preoperative clinically evident central lobe metastasis is identified, ipsilateral central compartment dissection is advised. In N plus neck, ipsilateral central compartment neck is advised. Focal berry picking of only clinically involved lymph nodes without compartment dissection leads to a higher rate of recurrence and should be abandoned. So berry picking is condemned. They advise that total compartment resection has to be done whether it is there is an involved node or even when there is an N0 neck, ipsilateral central compartment clearance should be done. Central compartment dissection is recommended for clinically node positive neck, and this therapeutic neck dissection involves removal of pretracheal prelaryngeal limb bearing tissue and unilateral paratracheal nodal removal. It was Kim et al. Who recommended bilateral central neck dissection when therapeutic lateral neck dissection is performed due to higher rate of occult metastasis. But there are many pros and cons. Some suggest only ipsilateral central compartment neck dissection suffices when we do lateral therapeutic neck dissection. If a lateral cervical lymph node metastasis is confirmed by biopsy, therapeutic neck dissection is recommended. Among the compartments, level 3 is the most common site of lateral cervical node metastasis. Most studies have agreed upon the necessity of removing nodes 2 to 4 based on distribution of lateral cervical neck node metastasis. So when there is lateral cervical neck node metastasis, neck dissection of levels 2 to 4 and 6 to generally be performed in case of lateral cervical neck node metastasis without involvement of level 1 or level 5. If there is recurrence, and if a compartment in which lymph nodes have not been dissected previously exhibit disease recurrence, nodal clearance in a compartment fashion should be performed. Means if there is disease recurrence post surgery, complete compartment clearance should be done. However, if the area has already been dissected, then the extent of nodal clearance should be decided after considering the oncological benefit of compartment nodal dissection clearance and the potential risk of clearance. This is most suitably for the central compartment because there is high chance of injury to the recurrent laryngeal nerve or to the parathyroid. So there has to be a balance between the extent of nodal clearance and the oncological benefit of nodal clearance so that these important structures are not damaged during the revision surgery. Some suggest if bilateral central compartment nodes are involved post surgery, so the compartmental dissection can be done in a staged manner as well. Role of adjuvant therapy. So in intermediate and high risk group, high dose radioactive iodine is recommended post operatively. As well, external beam radiation therapy is considered when patient is greater than 45 years old with gross residual disease and there is poor radioactive iodine response. There is high risk of microscopic residual disease and when there is a poorly differentiated histology. Role of neoadjuvant therapy. There is limited or no role of conventional chemotherapy in neoadjuvant setting. Lenvatinib is a multikinase inhibitor that shows robust activity in locally recurrent or metastatic progressive radioactive iodine refractory differentiated thyroid cancer. So lenvatinib can be considered in recurrent or metastatic and progressive and radioactive iodine refractory differentiated thyroid cancer. Very limited case series of using multikinase inhibitors have in locally advanced thyroid cancer have shown decreased morbidity and improved resectability, though some studies have shown. Now, who can do the this complicated surgery. Surgery for locally advanced thyroid cancer, it is a complex surgery requiring high volume experienced surgeon. It is a multidisciplinary approach involving the otorhinolaryngology, oncology, and vascular surgery. In India, access to such expertise and technologies like intraoperative nerve monitoring varies, where referral to centers of excellence is advised. So it is suggested that those who are doing more than 50 thyroid cases a year, they are more likely to do better surgery for locally advanced thyroid cancer. Summary of recommendations. Routine preoperative laryngoscopy and cross-sectional imaging is to be done for suspected invasion. Aim for complete gross tumor resection with preservation of function of important structures. Manage recurrent laryngeal nerve based on vocal cord function and extent of invasion. Use intraoperative nerve monitoring when available for nerve identification and monitoring. Apply full thickness airway resection for deep tracheal invasion. Employ adjuvant radioactive iodine and consider EBRT in high-risk cases. Surgery for locally advanced thyroid cancer is best performed in experienced center with multidisciplinary approach. These are the references. Thank you.